Welcome to this CME program. My name is Dr. Jean Elwing, and I'm a professor of medicine and the director of the Pulmonary Hypertension program at the University of Cincinnati. Thank you so much for joining me. I do have a few disclosures before we begin, listed here, both research and consulting. We are going to be talking about pulmonary arterial hypertension. This is a disease of elevated blood pressure or hypertension in the pulmonary arteries. Symptoms include things like shortness of breath with exercise, fainting spells known as syncope, dizziness, swelling in the ankles or edema, chest pain, or a racing pulse or palpitations. Some cases of PAH are due to a genetic abnormality in the bone morphogenic protein receptor 2, or BMPR2 gene, and this is inherited in an autosomal dominant pattern. Diagnosis is based on symptoms, clinical examination, and specialized testing. There are a number of treatments approved to manage symptoms of PAH, including phosphodiesterase 5 inhibitors, endothelin receptor antagonists, as well as prostacyclin, which becomes one of our mainstays of treatment in our sickest patients. And we can use these medications in combination. Since this is a rare condition, data presented at large medical conferences like what we're going to be talking about today, CHEST 2022, can get overlooked. So let's talk about that, CHEST 2022. This is the American College of Chest Physicians annual meeting. It was held in October, the 16th through the 19th of 2022 in Nashville, Tennessee. It is a large gathering of pulmonary-focused physicians, and we talk a lot about research in many diseases. And one that I'm always interested in is pulmonary arterial hypertension. Abstracts are published annually in a supplement to CHEST Journal. So let's start by taking a look at a few of the clinical trials we reviewed at CHEST. The first I would like to review is Freedom EV open label extension. Freedom EV is a study of pulmonary arterial hypertension patients, and it established that oral treprostinil delayed disease progression when added to oral PAH therapy. Patients could enroll in the open label extension after experiencing a clinical worsening event or when the study closed. Previously published analysis suggests that an overall survival benefit in PAH participants occurred when they took oral treprostinil active compound. Mortality was reassessed in this long final combined data set at the closure of the open label extension. In Freedom EV and the open label extension, all-cause deaths were recorded. A sub-study collected vital statistics every 6 months until Freedom EV study closure for patients who discontinued from Freedom EV, which was largely due to adverse events. There was a 36% relative reduction in risk of death for those initially assigned to oral treprostinil compared to those who initially were assigned to placebo. This was statistically significant, with an absolute risk reduction of 8.5%. This is important for a rare disease, which we have a difficult time impacting mortality with many of our medications. These data confirm initial analysis that oral treprostinil provides survival benefit for PAH participants and increases the evidence that oral treprostinil, when added to background monotherapy, improves a range of relevant clinical outcomes for our PAH patients. And you'll see here in this graph about survival probability over time. This is a time of 5 years and showing the separation of those who received active oral treprostinil versus those who received placebo. Now let's review oral treprostinil in a triple therapy regimen in that open label extension. As mentioned earlier, patients in Freedom EV could enroll in an open label extension after experiencing a clinical worsening event or when Freedom EV closed. It was important to note that patients could add a third class of pulmonary hypertension medications, one that they were not on when they transitioned to the open label extension, after enrolling. Patients originally assigned to oral treprostinil that enrolled in the open label extension and added a third class of PAH therapy were included in this analysis. Safety and efficacy were assessed at the start of the open label extension and every 12 weeks until voluntary discontinuation or study closure. Efficacy measures included 6-minute walk distance, functional class, and NT-proBNP. It was noted that adverse events, especially GI side effects, especially diarrhea, was attributed to oral treprostinil and more common in those patients on triple therapy as compared to those on dual therapy. And it was more likely to be severe and lead to oral treprostinil discontinuation. So let's look a little bit at this data. We're looking at 6-minute walk distance, NT-proBNP, and functional class at baseline, week 48, and week 72. And we see an incremental improvement in walk distance and a decline slightly in the NT-proBNP, and functional class improved in 28% of patients and remained stable in 69% of those individuals that were assessed in this analysis. So now we're going to change gears and talk about real-world data on pulmonary hypertension therapies. Now, we have a lot of experience in different sort of medications, initiation and continuation, but we are lacking in experience in transitioning from one medication to another. Experience from transitioning from prostacyclin infusion therapy to oral therapy was presented at CHEST 2022. A retrospective case series of 6 patients that safely transitioned from parenteral to oral PAH therapy was reviewed. An electronic medical record database search was used to identify adult patients with Group 1 PAH that transitioned from parenteral to oral therapy from 2016 to 2021 at an accredited pulmonary hypertension center. They looked at 145 adult patients with PAH on parenteral prostacyclin therapy, and 8 transitions were identified. The primary outcome of interest was comprised of functional class and walk distance pre and post transition, as well as identification of patients who failed transitions. Of the 8 patients who transitioned, 6 were planned and 2 were emergency transitions. The 2 emergency transitions were not included in the final analysis. The average age of those transitions were 50 years of age, and at the time of diagnosis of PAH, all were functional class 3 and 4 with an average REVEAL score of 11. Prior to transition to oral therapy, all had improved to functional class 2. Most began their transition as an outpatient and completed transition off parenteral therapy inpatient. At 12 months post-transition, there were no readmissions and all patients had remained on oral therapy. Data suggests patients with PH on parenteral therapy with good functional status and optimized hemodynamics may be able to transition to oral therapy without functional decline, even in patients with high risk at diagnosis. And if you look at this table here, we see the average prostacyclin dose pre-transition was 31 nanograms per kg per minute. The average time on infusion therapy was 34 months, with 5 of the 6 individuals who transitioned already on oral therapy at the time of transition. Functional class, as I mentioned, all were functional class 2 at the time of transition, but that had improved from 3 and 4 when they were initially diagnosed. And 6-minute walk distance pre-transition was 489.2 and was maintained at that 6 to 12 month point post-transition. So giving us hope for our patients that there may be options that could be in the future for individuals needing parenteral prostacyclins at the time of diagnosis. Now let's talk about another medication in that prostacyclin pathway. Let's talk about the impact of initiating Selexipag 1 year or less after a PAH diagnosis. And this was discussed and presented at CHEST. A retrospective cohort study of patients 18 years or older with newly diagnosed PAH between October 2015 and September 2019 was completed. A 12-month landmark analysis following the initial PAH diagnosis date was applied to classify patients who either were initiated on Selexipag within 12 months of the PAH diagnosis or those who did not initiate a prostacyclin pathway agent within that time frame. All-cause hospitalization rates and total annualized medical costs were assessed from the landmark time point until the earliest of study end or data censoring by cause of death disenrollment, or a diagnosis of chronic thromboembolic pulmonary hypertension. SelectSpeg started at 1 year or less was associated with a 24% lower rate of all-cause hospitalization as compared to no prostacyclin pathway agent during that time period. This was statistically significant. This evaluation showed us that the initiation of SelectSpeg within 12 months of PAH diagnosis was associated with reductions in all-cause total medical costs attributable to fewer hospitalizations, as well as lower hospitalization and outpatient costs compared to PAH patients who did not initiate a prostacyclin pathway agent within that time frame. Now let's look at this table looking at those individuals receiving SelectSpeg at 12 months or less. Total annualized medical costs were $33,000, less than nearly $60,000 for those who did not receive a prostacyclin pathway agent. Cost associated with hospitalization, $14,000, about half of the other group. Costs associated with outpatient visits, also lower. And the total medical costs confirmed by multivariate GML, again, significantly lower. So this is something to trigger us to think about the timing of our medication additions in our PAH patients. Now let's review data from the CTEPH registry, showing us the greatest impact on quality of life improvement occurred in patients who were treated with pulmonary thromboendarterectomy, which is surgery, versus our other modalities, which include medication and catheter-based treatments. The purpose of this investigation was to evaluate the SF36 and emphasis 10 results over time in patients newly diagnosed with chronic thromboembolic pulmonary hypertension. Patients with CTEPH were recruited from 30 U.S. sites between April 2015 and March 2017. Participants were classified as follows: operated, who had that pulmonary thromboendarterectomy, operable without surgery, and inoperable patients. Patients completed the SF36 and emphasis 10 surveys at baseline and at 6-month intervals. A total of 750 patients were enrolled in the study, and 715 completed at least one survey. 566 were operated, 88 were operable but no surgery, and 96 were inoperable. Scores for the emphasis 10 and SF36 improved during follow-up for all three groups, with the greatest improvement versus baseline in those who received surgery, that pulmonary thromboendarterectomy. At baseline, patients with CTEPH have high symptom burden based on the emphasis 10 scores and significant impairment in their health status based on their SF36 physical and mental components. As mentioned, while all three groups showed improvement versus baseline, the greatest improvement was seen in those patients who received surgery. Now let's move on to some adherence data. Adherence to guidelines that was presented and showed the majority of PAH patients are not receiving optimal initial treatment. Guidelines for PAH recommended upfront dual therapy with an endothelin receptor antagonist and a phosphodiesterase inhibitor in newly diagnosed PAH patients. An analysis presented at CHEST evaluated real-world treatment patterns of initial PAH regimens. A retrospective claims database study using Optum de-identified ClinInformatics, Datamark, and Equivia Parametrics was assessed. Findings suggested that the majority of real-world initial PAH regimens are comprised of monotherapy PDE5, guanylate cyclase stimulators, or endothelin receptor antagonist therapy. The use of upfront dual therapy slightly increased, but remains significantly lower than acceptable in our patient population. Utilization of PAH centers of excellence was also looked at CHEST and presented. Guidelines highlight the importance of expert referral. When patients are diagnosed with PAH, it is recommended for patients to be seen in an expert center. retrospective exploration of the proportion of patients with PAH in Texas receiving PAH-specific therapy who visited an adult PAH Center of Comprehensive Care, a CCC, was presented. Data was drawn from a repository which links open source medical claims, prescription claims, and electronic health records. In this small cohort, 537 adult patients, fewer than half of them visited a comprehensive care center. Now, there are centers that are not certified, and that could lower the total number of patients seen by experts, but still prompts significant concern that patients are not being sent or referred to prescribers and providers that are experienced in PAH management. So now we're going to switch gears and talk about real-world data on survival. Survival in PAH patients requiring mechanical ventilation was presented. This is a high-risk group of patients. PAH, as I mentioned, is a rare disease and is associated with elevated pulmonary pressures and characterized by an arteriopathy that leads to stress and strain on the right ventricle and right ventricular failure. Management of patients in the ICU is challenging, and there's lack of evidence based on guidelines to direct us to optimal management. The goal of this investigation was to evaluate characteristics associated with poor outcomes in PAH patients requiring urgent intubation and mechanical ventilation. A retrospective analysis was conducted and included all patients admitted to the ICU at a large academic hospital between January 1st, 2010 and June 1st, 2021, and looked at those patients who required urgent intubation and had an ICD-10 code consistent with PAH, and they were on PAH-specific medication. This data confirms a high mortality, as you will see here, of 56% associated with intubation and mechanical ventilation in our PAH patients. And I'd like to direct your attention to the data here, looking at 19 of 32 patients passed during hospitalization. 14 of 32, 44% survived until discharge with an acceptable cumulative survival. So a large number of patients came to the hospital with respiratory distress or another condition needing urgent intubation and did not survive that hospitalization. Now let's look at survival in our patients with chronic thromboembolic disease. Survival improvements in our patients who have chronic thromboembolic disease is associated with undergoing thromboendarterectomy. The goal of this investigation was to evaluate the long-term outcome in patients with chronic thromboembolic disease, which is referred to as CTEPH. Patients with CTEPH diagnosed within 6 months of enrollment in this registry were recruited from 30 U.S. sites between April 2015 and March 2017. Patients were classified as operated who underwent pulmonary thromboendarterectomy, operable without surgery, and those who were inoperable. Survival models were completed looking at each CTEPH group, unadjusted, and after inclusion of variables significantly associated with survival in the univariate analysis. A total of 750 patients were enrolled in the study. 715 completed at least one survey. 566, 88, and 96 were operated, operable but no surgery, and inoperable, respectively. The risk of death was higher in CTEPH patients in the inoperable or those who were operable without surgery relative to the group that underwent a definitive surgery for this condition. This persisted after adjustment for comorbidities and baseline hemodynamics. If you look here at this graphic, survival was 93% at year 1, 91% at year 2, and 87% at year 3 in the operated patients. Hospitalizations were lower in those PTE patients with 25, 32.9, and 37.9 hospitalizations per 100 person years for the operated, the inoperable, and the operable without surgery groups, respectively. Lastly, we're going to touch on some monitoring parameters that were discussed at CHEST. Let's look at TAPSE over right ventricular systolic pressure on echo as a clinical outcome measure. Resting echocardiography is routinely used in PAH clinical assessment. However, the role in exercise stress echocardiograms in risk assessment is not well defined. The ratio of tricuspid annular plane systolic excursion to right ventricular systolic pressure, that TAPSE over RVSP, obtained by transthoracic echocardiography, is validated, and it's a non-invasive surrogate measure for RV-PA coupling. This study measures TAPSE over RVSP at rest and during exercise in patients with PAH to assess exercise-related changes and correlate findings with subsequent adverse outcomes. 8 of the 30 eligible patients, 21%, underwent lung transplant or passed away during the clinical follow-up through March 2022. TAPSE over right ventricular systolic pressure ratio declined during exercise, and values less than 0.25 were significantly associated with increased risk of mortality or need for transplantation. Exercise, in addition to what we see at rest with echocardiography, may improve the prognostic accuracy of the parameter of TAPSE over right ventricular systolic pressure. This study showed us echocardiography derived TAPSE over RVSP ratio is an easily obtainable, non-invasive measure, and it shows us how the RV and the PA are coupling. Both resting and exercise TAPSE over right ventricular systolic pressure are higher in survivors. Now I'd like to point your attention to this graphic looking at the TAPSE over right ventricular systolic pressure ratio, looking at both resting and during exercise, and those in the orange being survivors and the darker reddish orange being the non-survivors, with that ratio being lower in those non-survivors or transplanted individuals. Now we'll end with a look at comparing PAH risk assessment tools. Risk assessment is extremely important in our patient assessment. There are several available, and we may use one or the other. In this assessment, the performance of PAH risk assessment tools were compared. A harmonized data set of patients with several patient clinical trials were included, and this was used in this analysis. In the same data set, the following risk assessment methods were applied. First, the new version of the Pulmonary Hypertension Outcomes and Risk Assessment, or the FORA model 2.1, using random, forest, and Bayesian network analysis was employed. Second, the Registry to Evaluate Early and Long-Term PAH Disease Management, or REVEAL 2.0 and REVEAL Lite 2.0 was used. Third, a 3 and 4 strata comparative prospective registry of newly initiated therapies for pulmonary hypertension, or COMPARA 2.0, was assessed. And fourth, the non-invasive French pulmonary hypertension registry scoring was used. Discrimination performance to predict 1-year survival was compared between these methods using the AUC after 5-fold cross-validation, and Wilcoxon signed rank test was assessed. A data set of 494 PAH patients was used for this analysis. All of these tools performed very well at assessing risk of death within 1 year. The FORA 2.1 model, based on a Bayesian network analysis, depicted the highest AUC to predict the outcome of survival compared to the other PAH risk assessment methods that are widely used. With the FORA 2.1 method, including 13 variables, showing an AUC of 0.84 after the 5-fold cross-validation, with the French having an AUC of 0.71, the COMPARA of 0.78 and 0.72, and REVEAL Lite and REVEAL 2.0 at 0.8 and 0.81. So as I mentioned, all tools are predicting survival very well, but this is just a comparison of what we frequently use in our patients. So to close, I would like to leave you with several clinical pearls that we learned at CHEST 2022. As mentioned, PAH is a rare disease. It's characterized by hypertension or high blood pressure in the pulmonary arteries. CHEST 2022 was held in October, the 16th through the 19th in Nashville, Tennessee. Abstracts from CHEST were published in a supplement issue of the CHEST Journal. FDA-approved oral treprostinil continues to demonstrate a benefit, even when added to a triple therapy regimen in the Freedom EV open-label extension. Patients with PAH on parenteral prostacyclin therapy with good functional status and optimized hemodynamics may be able to transition to oral therapy without functional decline. Initiation of selexipag within that first 12 months after PAH diagnosis is associated with a reduced cost related to their medical expenses and reduced number of hospitalizations. In CTAP patients, quality of life improvements were seen over time in all three patient groups, including operated, operable without surgery, and those who were inoperable, with the largest improvement seen in patients who underwent definitive surgery with pulmonary thromboendarterectomy. The majority of real-world initial PAH regimens comprised of monotherapy, either a PDE5, a guanylate cyclase stimulator, or an endothelin receptor antagonist. Upfront dual therapy is recommended in the guidelines and has increased slightly over time, but remains low. We also learned from CHEST that the proportion of patients with PAH who visit a PAH center of comprehensive care is likely lower than we would like to achieve based on guidelines. We learned that patients with PAH who are sick, hospitalized, and require urgent intubation have a high risk of mortality, and we need to be aware of this when caring for our patients who are critically ill. Patients with CTAP who underwent PTE or pulmonary thromboendarterectomy had the lowest subsequent mortality and hospitalization rates as compared to those who were operable and did not undergo surgery and those who were inoperable. We talked about echocardiography. Both resting and exercise TAPSE over right ventricular systolic pressure were higher in our PAH survivors, excluding those who underwent transplant. Values of 0.25 or less were associated with an increased risk of mortality and transplant need. And lastly, FORA 2.1 method of risk assessment allowed better PAH risk assessment discrimination as compared to the other methods that were studied and presented at CHEST. With that, I will end. Thank you so much for joining me. I hope you enjoyed this CME session.